Okay, so let's talk about pneumothoraxes and pleural effusions. So a pneumothorax is basically a collapsed lung, right? The lung actually is usually adhered to the inner chest wall by the pleura. And if it separates, which sounds pretty painful, and it is, it collapses, causing a pneumothorax. So if there's no, so basically there's air in the pleural space now because the lung has collapsed and separated from the chest wall. If it's a simple pneumothorax, what that means is the air that's in the pleural space is not under pressure, right? Now, could it affect ventilation because the one lung has collapsed? Absolutely. Does it cause chest pain and shortness of breath? Definitely. A complication of a pneumothorax is a tension pneumothorax, where air is continually going into the pleural space and building up in pressure because of a leak from that lung that's collapsed, and more air is going in and it has nowhere to exit. In a tension pneumothorax, the pressure is building up on that side of the chest and it's going to push everything over to the other side of the chest. Okay, so you're still going to have hyperresonant lung sounds on that side. You're still going to have chest pain on that side. You're going to be short of breath, right? But on top of that, the pressure has moved everything to the other side of the chest, and it's going to block return of blood to the heart because of the high pressure in the thoracic cavity. So what are the signs of a tension pneumothorax? Distended neck veins. Tracheal deviation to the unaffected side. Everything's being pushed over, right? Hypotension, again, because there's no blood returning to the heart. Tachycardia, again, because the heart's trying to pump out blood, but it doesn't have enough to pump out because of the tension pneumothorax. Okay, so tension pneumothorax is an emergency. We have to do something right away, and typically we put a needle directly into the pleural space and to release the pressure. Once we've solved the tension pneumothorax, we still have a pneumothorax, and we put a chest tube in and attach it to an underwater seal to resolve the pneumothorax. Okay, so we fix the tension pneumothorax first with a needle decompression it's called, and then we fix the simple pneumothorax that we've converted to with a chest tube. A pleural effusion, just a collection of fluid in the pleural space. And if they're large, what happens is they stop expansion of the lung on that side, and that impedes ventilation, right? So often we need to drain pleural effusions if they're large enough to allow the lung to expand properly. Okay, so if we look at the lower left image, that's a pneumothorax, right? The presence of air in the pleural space, and the lung has fully collapsed, okay? And if that pleural air is not under pressure, we'll call it a simple pneumothorax. How do they present? Sudden onset of chest pain and shortness of breath on one side, okay? And then we can diagnose it with a chest x-ray, seeing the collapsed lung, okay? What's the complication of a simple pneumothorax? A tension pneumothorax. The air has become under pressure and shifting everything over to the other side of the chest cavity, okay? And that's the problem. So just think of the mechanics of what's happening, that high pressure in the thoracic cavity, and you can figure out all the signs and symptoms. Shortness of breath, anxiety, distended neck veins, hypotension, tachycardia. Those are all tension pneumothorax, okay? What's a hemothorax? The top left. It's a collection of blood in the pleural space. So what typically gives you that? An accident or trauma to the chest. And vessels bleed in the pleural space and develop a hemothorax. Okay. What's a pleural effusion? Well, a pleural effusion is just a collection of fluid in the pleural space. That's it. okay, for whatever reason, whether it's congestive heart failure, or some disease in the pleural space and there's a collection of fluid, is called a pleural effusion. An open pneumothorax is just where you've had something impale your chest and gone through your chest, and it's collapsed your lung, and it's open to the outside world, right? So in that case, we need to seal that hole with whatever bandages or anything to seal the hole, so that air isn't being sucked into the pleural space from the environment. So just keep the different conditions separate. Pneumothorax, collapsed lung. Tension pneumothorax, well, it's a collapsed lung with increased pressure now, causing a whole host of new symptoms. Hemothorax, blood in the pleural space. Pleural effusion, fluid in the pleural space. Okay. What do we do for a tension pneumothorax? We put in a needle directly into the anterior chest to decompress the chest of pressure. We still have the pneumothorax though. So what do we do for a pneumothorax? We put a chest tube in and re-expand the lung. What do we do for a hemothorax? Well, a hemothorax, as it gets bigger and bigger, we want to drain it because it's stopping the lung from expanding. So we'll put a chest tube in and drain the blood. We'll monitor the output of the chest tube of how much drainage there is from the pleural space. Same thing for a pleural effusion. What can we do? We can put a chest tube in, or we can aspirate it with a thoracentesis, right? Put a needle in when we're talking about a thoracentesis, and we drain the pleural effusion. Okay, so let's look at the risk factors for pneumothorax, okay? Just a collapsed lung. Typically just on one side. I mean, you can have a collapsed lung on both sides. That's not good, right? Because now you can't ventilate since both lungs are collapsed. Most of us with healthy lungs can continue to breathe and ventilate with one lung, at least temporarily, okay? So blunt chest trauma. So a major injury to the chest. Remember, the lungs are like balloons, right? They're attached to the inner chest wall. So a significant chest trauma can collapse a lung and lead to a pneumothorax. A penetrating chest wound, so say a knife wound to a chest that punctures through the pleura, is going to cause the lung to separate from the pleura, leading to a pneumothorax. What about someone who already has a pneumothorax or is getting a chest tube? Well, we could potentially collapse the lung while putting in the chest tube, right? So say we're putting in a chest tube for a pleural effusion to drain it, and by accident we hit the lung. Well, we can cause it to collapse. Okay. Patients with COPD. So patients with COPD have scarring to their lungs, and they develop almost like blebs and blisters on the outer part of their lung, and some of those can pop. Okay. So they have very abnormal lungs because of the alveolar destruction, and they get these blebs. And if a bleb were to break in someone with COPD, the whole lung collapses, causing a pneumothorax. And the last one, and probably one of the most common, is a young person, a young, tall person. And it's called a spontaneous pneumothorax, where they're just walking along and suddenly, boom, their lung collapses. So why is that? Well, a tall, thin person typically has tall lungs, right? They have a higher level between their upper lung and their lower lung. And because the lung is spread out more, it has the potential to collapse spontaneously, okay? Because the pressures are slightly different in those patients. So if you were to think of someone just walking along and their lung collapses, it's typically a tall, young person that it happens to, okay? And they come in and say, I have terrible chest pain and I'm short of breath. And we do a chest x-ray and we see that their lung has collapsed. with no injury at all. Okay. Now, the image on the right is showing you a pleural effusion. Okay, that's not a pneumothorax. A pleural effusion is a collection of fluid in the pleural space. Okay, keep them separate. If you have a pneumothorax, it does not mean you have a pleural effusion at all. It means you have air in the pleural space. Okay, I'm gonna repeat myself here for simplicity. A pneumothorax is just a collapsed lung. There's no image of it here, just a collapsed lung. A tension pneumothorax, it's a collapsed lung that has air in the pleural space, just like a pneumothorax, but now it's air under pressure, right? And it's going to move everything, it's going to shift everything over to the other side of the chest cavity. Okay, that's a tension pneumothorax. Pleural effusion, collection of fluid in the pleural space. Okay, so, and what's a hemothorax? Well, it's a collection of blood in the pleural space. Okay, so now let's talk about a flail segment. What's a flail segment? It, usually from an accident, it is rib fractures, so 2 rib fractures at each rib and 2 or greater ribs. Okay, so now you have a segment that's not attached to the rest of the chest wall. So when that person takes a breath in, well, there's negative pressure in the chest. And as the chest is expanding, that segment's going to go inwards, as you can see in the image in the bottom there. When they breathe out, that segment's not attached to the chest wall, and there's positive pressure during expiration, that segment's going to bulge out because it's completely independent from the rest of the chest wall. Okay? What are you going to get with a simple pneumothorax? Well, person's going to come in with chest pain on that side and shortness of breath. It hurts to take a breath. Okay, so we examine them. They have hyperresonant lung sound on that side. There's no lung there anymore. There's just air. So it's going to be hyperresonant when we percuss it. When we listen to it, it's going to be absent breath sounds on that side. Okay, that's a pneumothorax. Tension pneumothorax. It's going to have the same findings. When we percuss, it's going to have hyperresonant lung sounds on that side. When we listen, there's going to be absent breath sounds. What else is there though? It's now a tension pneumothorax. Everything has shifted over to the other side because of the high pressure. So now you have tracheal deviation to the unaffected side. You have distended neck veins because the blood can't get back into the thoracic cavity. You have tachycardia. The heart's trying to maintain cardiac output, but there's no blood coming back to the chest. So they're hypotensive because the blood's not getting back to the right side of the heart, so it can't get to the left side of the heart. Okay, so all of the signs and symptoms will make sense if you understand what's happening. Okay, what's going to happen with a flail segment? Well, if it's a large flail segment, the person's not going to be able to ventilate properly because every time they go to take a big breath, part of their chest wall goes inwards. So these patients may need mechanical ventilation because they're not able to expand their lungs well anymore because there's a large chunk of the chest wall that's going inwards during inspiration. Okay, what's subcutaneous emphysema? Well, that can happen with any pneumothorax, and what it is the air that's in the pleural space has tracked into the tissue, and when we touch the tissue of the skin, in the area in the chest that has the pneumothorax, we can feel almost like Rice Krispies under the skin, and that's air that's in the tissue. Okay, so keep them all separate. They're all actually separate conditions. Okay, again, we're going to keep them separate. In pneumothorax, what do we want to do? We want to re-expand the lung. Okay, how are we going to do that? If it's a simple pneumothorax, we're going to put in a chest tube. And we're going to attach the chest tube to the underwater chambers, right below the level of the bed and upright. And you can see the chamber at the bottom right there. Okay, and you can see the chest tube coming from the chest in the upper right. So we're going to, so in pneumothorax, what are they going to have? Hyperresonant lung sounds, hyperresonance to percussion, decreased air entry on the affected side. Okay, that's a pneumothorax. A hemothorax, a collection of blood in the pleural space. What do we want to do? We want to put a chest tube in to drain the hemothorax. Okay, and we're going to monitor how much blood is coming out of the chest tube. Okay, so that's the whole intention of a hemothorax, is to drain it. A pleural effusion, collection of fluid in the pleural cavity, in the pleural space. What can we do? We can drain it, whether it's with a thoracentesis, which is just a needle, or with a chest tube, which is more invasive, but we can drain large pleural effusions. Okay, patients often need some kind of sedation, such as a benzodiazepine, or an opioid analgesic, such as fentanyl or morphine, to decrease the pain. Okay, with these procedures, whether it's a chest tube, definitely with a chest tube or thoracentesis, we also freeze the tissue, right? We give it a really good local anesthetic. Okay. Okay. This is probably repetitious, but that's how you remember things. So pleural effusion, okay, it's a collection of fluid in the pleural space from any cause, and gradually, as the pleural effusion gets bigger and bigger and bigger, as you know, we're looking at a left pleural effusion here, it's going to squash the lung. It's going to move that lung out of the way. So it's going to make it hard to breathe. And that's why we'll either do a thoracentesis, where the person's leaning on a table and we're freezing their back and putting a needle into the pleural space to drain the fluid, or we could drain it with a chest tube. Okay. Now, how does that differ from pulmonary edema? Well, pulmonary edema is typically from congestive heart failure, so from left ventricular heart failure, and it's backing up into the lungs. Well, that definitely doesn't need a chest tube or thoracentesis because all the fluid is within the lung, right? It's not in the pleural space. So how do we treat that? Well, we can treat pulmonary edema with diuretics to drain fluid out of the patient's system. We can treat it with medications that can help the heart pump better, so it's not backing up into the lungs as much, right? And there's many medications to do that. Okay. Pulmonary embolus, that's where we're looking at a blood clot that travels to the lung and blocks one of the pulmonary vessels in the lung and damages the lung. Okay, so they're all very different conditions, and they're often not associated with each other. So just know them in isolation of each other. Okay. Okay, so let's do these questions together at the end of the chapter. Number 1, so this is the chapter on pneumothorax and flail chest, by the way. A nurse is assessing a client following a gunshot wound to the chest. For which of the following findings should the nurse monitor to detect a pneumothorax? Okay, pneumothorax, collapsed lung. Okay, now, if it's a simple pneumothorax, it's just a collapsed lung. If it's a tension pneumothorax, it's a lung that's collapsed, but now the pleural space has high pressure in it, and it's going to cause those other symptoms: distended neck veins, tachycardia, hypotension, tracheal deviation. Okay? Okay, let's look at the answers. Tachypnea, absolutely. If you have a collapsed lung of any kind, you're going to be breathing faster to try and maintain oxygenation. Tracheal deviation. So here's where it gets confusing because they didn't tell you if it's a simple or a tension pneumothorax. Let's just assume it could be either one of them. Tracheal deviation, absolutely. Okay, so if there's a tension pneumothorax, which by the way is quite uncommon. Tension pneumothorax is uncommon. I don't want you to think it happens all the time compared to a simple pneumothorax. Anyways, tension pneumothorax, you got deviation of the trachea to the unaffected side, right? To the other side of the chest. Bradycardia, definitely not. You're going to be tachycardic. Decreased use of accessory muscle use. No, you might be using your accessory muscles because one of your lungs has fully collapsed and you need to continue ventilating, breathing, right? So no, D is not correct. Pleuritic pain, absolutely. This lung has separated away from the pleura, which is exquisitely sensitive with lots of nerve endings. You are going to have a lot of pain on the side of the pneumothorax. So the answer is A, B, and E. 2. A nurse is assisting the provider to care for a client who has developed a spontaneous pneumothorax. Which of the following actions should the nurse perform first? Okay, spontaneous pneumothorax is typically a tall, young person and their lung just suddenly separates from the pleura and they get a pneumothorax. Okay, which of the following actions should the nurse perform first? Assess the client's pain. It's going to be A, B, and C coming into here. So assessment of pain isn't number one. It's important, but it's not going to be as important as airway, breathing, circulation, right? Obtain a large bore IV for decompression. Okay, so here's where it starts to get confusing in ATI again. If it's just a simple pneumothorax, meaning the lung has just collapsed, we're going to re-expand it with a chest tube because typically it's not a tension pneumothorax. In these questions, they're just assuming that they're all the same. So they're calling a spontaneous pneumothorax has now been complicated into a tension pneumothorax, which often isn't the case. But let's just assume that they're asking for any pneumothorax. So B would be the answer. You want to put a needle through the chest wall to take the pressure out. Okay, so B would be the answer. Administer lorazepam. No, that's just a sedative. Don't need it right now. That's not the first thing you would do. Prepare for chest tube insertion. Well, that would actually be the answer I would choose because most spontaneous pneumothoraxes are not under pressure, and we would just tell the patient that we need to re-expand their lung and put in a chest tube. With these questions, they're just assuming that it could be any kind of pneumothorax, tension or just a simple pneumothorax. So the answer would be B because you would need to decompress the pressure, take the pressure out of the chest before putting in a formal chest tube. Okay, so B. 3. A nurse is reviewing discharge instructions for a client who has COPD and experienced a pneumothorax. Which of the following statements should the nurse include? So COPDers have those blebs and blisters on the surface of their lungs, and if they pop, they get a pneumothorax. Okay, which of the following statements should the nurse include? Notify the provider if you experience weakness. Okay, that's pretty non-specific. You should be able to return to work in 1 week. Not necessarily, right? If your pneumothorax isn't re-expanding very well, you may not be able to return to work in a week. C, you need to wear a mask when in crowded areas. No, there's nothing infectious going on here, right? You have a collapsed lung. Notify your provider if you experience a productive cough. This one's not really that clear, but so the person has a pneumothorax, a collapsed lung. So if they're being treated for a collapsed lung, there is a risk of the lung getting infected since it's been collapsed. So you would notify someone if you're starting to cough up productive phlegm because that can be a sign of infection. Okay, I'm not a big fan of this question at all.
Okay. Number 4, a nurse in the emergency department is assessing a client who has sustained multiple rib fractures and has a flail chest.
Okay, so a flail chest means that there's a segment of the chest wall that is completely not attached to the rest of the chest wall. Okay, so 2 fractures in each rib and more than 2 ribs. So 2 or greater ribs, sorry. Okay, so which of the following findings should the nurse expect? Bradycardia. No, they wouldn't be bradycardic, right? Even if they had, even just for the sake of discussion, they have pain, they'd be tachycardic. They wouldn't be bradycardic. Cyanosis, that is totally possible because they're having problems expanding that lung because there's a loose segment of chest wall that's sucking inwards, right? Paradoxical breathing. So they could be cyanotic. Hypotension, they could be hypotensive, right? So they could be hypotensive because possibly the lung behind the flail segment could be collapsed. They may have a tension pneumothorax behind that flail chest. So they could be hypotensive. Shortness of breath or dyspnea, absolutely. They could be short of breath because they're having difficulties ventilating. Paradoxical chest movement, absolutely, because of that loose flail chest segment. Okay, so B, C, D, and E. The only one I don't like is C, hypotension, because the loose segment in it by itself is not making you hypotensive, right? That's just a loose segment of the chest wall. It's definitely affecting your breathing, but what's making you hypotensive? So I find that just an unfair, I mean, they likely will be hypotensive because they could have a tension pneumothorax behind the flail chest, but you'd have to infer that by the question, and I don't really find that one to be clear.